Hello, good afternoon, or good morning, everyone. Thank you for joining us today. We are so excited to have you here. We're going to get started in just a few minutes to allow people time to join. Hi, everyone. Again, good morning or good afternoon. Thank you for joining us today. I'm just going to give folks one more minute to join and then we will kick this off. All right. Hello, everyone, and thank you so much for joining us today. To kick things off, I'll briefly introduce myself. My name is Emily Anders, and I'm the Director of Payment Strategy here at Unite Us, and I will be your moderator for our panel discussion. Before we dive in, just a quick housekeeping note. We will be monitoring the Q&A box throughout the session, and we've reserved time at the end for a live Q&A. So please feel free to submit your questions in that box as we go, and we'll do our best to answer as many as we can. All right, let's get started. Thank you again for joining our Medicaid Transformation webinar series today, where we're bringing together different stakeholders who are doing this work across the country to share challenges, lessons learned, and best practices they've identified on the ground. This is actually our second webinar in the series, but if you didn't get a chance to attend our first one back in December, I would highly recommend watching the recording that is posted on our website. So in that session back in December, we brought together community-based organizations participating in Medicaid waivers, billing Medicaid for the first time, and got a lot of great insights on their transition into billing Medicaid for providing these non-medical services. In today's session, we're more focused on the payer experience, and we're joined by Medicaid payer leaders across the country in active 1115 Medicaid waiver states. So when they introduce themselves, when I finally stop talking, you will hear that their states are in very different phases of what I'm going to call their Medicaid waiver journey. And we're so lucky to have them today to share their experiences and their varying perspectives with you all. So before we dive into our discussion, I'd like to take a moment to finally introduce you all to our stellar panelists. We are joined by Faith Sample Smart from Carolina Complete Health, Liz Whitworth from the Oregon Health Leadership Council, and Rhonda Hambleton from Aloha Care. So to kick us off, I'd love for you all to briefly introduce yourselves, share a bit about your organization, specifically its role within the Medicaid ecosystem, and where you currently are, what I'm going to call your Medicaid transformation journey. So Faith, let's start with you, followed by Liz and then Rhonda.
All right. Thank you so much. I appreciate the warm introduction. So I am Faith Sample Smart. I am the Director of Population Health Strategy at Carolina Complete Health. My program here, well, our 1115 waiver started in 2021. We, like everyone else, was postponed as a result of COVID. So we launched in July of 21. We've been running ever since. We also have another 1115 waiver that is the first of its kind, the Healthy Opportunities Pilot, which is focused on providing support for non-medical drivers of healthcare outcomes. And the HOP program sits under me as well. And I am located here in Charlotte, North Carolina. So I'm going to apologize up front for any background noise. I'm sitting in my car because I have to run into a doctor's appointment immediately after this. So
Thank you, Faith. And like I said, we're very lucky to have Faith, Liz, and Rhonda join us. So thank you for making it work with your schedule, Faith. Okay, let's go over to Liz from OHLC.
Hi, everyone. Thanks, Emily and team, for having me. I am Liz Whitworth. I'm Managing Director of the Oregon Health Leadership Council. So we are a statewide collaborative here in Oregon that brings together the health plans, our MCOs, hospitals and health systems, and key association groups to really do strategic projects together. And one of those has been supporting the adoption of the Unitas technology since 2019 in our state to build what we call Connect Oregon, which is our statewide closed loop referral network. So that's been building, through the COVID pandemic. Our current 1115 waiver in our state started in 2022, runs through 2027. And the health related social needs component really just started a year ago. So we're very early in the social needs space. Our state Medicaid agency actually delegated the implementation of those services to our MCOs, which are known as CCOs here in Oregon. And through that work, OHLC partnered with 10 of those MCOs in our state to use the Unitas technology to support some of the implementation work that we'll talk about later today. Thanks.
Thanks, Liz. And last but certainly not least, let's go over to Rhonda.
Hi, good morning. My name is Rhonda Hamilton, and I am the Director of Product Management, both Medicare and Medicaid lines of business at Aloha Care. Our work, Aloha Care is very unique. We are a nonprofit health plan in Hawaii, and we were founded over 30 years ago by our local community health centers. Representatives of these health centers make up our board of directors. So that's a little bit of background of our company. We are one of 5 health plans in Hawaii, and we pride ourselves in being the local health plan, meaning all of our staff is local. We do not have any ties to a mainland corporate entity. This can be challenging in some ways, right? Because if there's any change that's needed, we're doing it here in-house. We don't have a corporate IT department or something like that to help support. Within our Medicaid system, we collaborate very closely with the other 4 health plans and with the state Medicaid partners on all changes to the Medicaid program. This has been a fairly new process that the state has really initiated, but it's been a very, very effective approach in implementing changes to Medicaid. With the approval of the 1115 waiver in early January, we have started work group meetings with the state and other health plans to start talking through the implementation of the new programs.
Awesome. Thank you, Rhonda. Thank you, everyone. So again, like Rhonda, Liz, and Faith mentioned, North Carolina was launched several years ago for their 1115 waiver. Oregon, just last year, right, Liz? And then Rhonda, you all are kind of in that planning and strategizing phase. So all different phases, and I'm excited to kind of dive into those learnings that you all have to share. So first question for all of you, as we all know, Medicaid transformation looks very different across the country. So from your perspectives at Aloha Care, OHLC, and Carolina Complete Health, what innovative strategies or approaches have you seen in your states that could serve as models for others? Faith, let's start with you on this one.
Yeah, I think I think the underlying premise is probably universal, which is really whole person health, integrating all of the aspects of a person's health, not only looking at the medical and the mental health, but also looking at those social determinants of health. And so we've spent a lot of time in our implementation process doing that, really looking at the whole person. How do we serve that entire entity? And then with social determinants, we know here in the state, there are 4 priority areas for the state around social determinants of health. Those are food insecurity, home stability or health instability, transportation, and interpersonal violence. Outside of that, we as a health plan are focused on many other areas. But what the state has done in their waiver was to create what are called mandates in a contract. There are 5 health plans here in the Medicaid space that are providing service for Medicaid members. What the state did was require each of the health plans MCOs to have what are called value-added services. Those are services above and beyond their standard plan benefits would provide. And so we have all come up with a range of options in that category. Some of them are overlapping across the various MCOs, and then others are unique and different. So that's one space where we spent a lot of time really developing, trying to figure out what works well for our members and being able to adjust that and change that through our state contract on an annual basis. Do we need to add more of this or drop something that's not really being used widely? Are we providing sufficiently for children and families? How does that look different for us when we picked up our Medicaid expansion population at the end of 23? What did we need to do to adjust and pivot for that adult population that looked very different from largely the women, the children, and the elderly population that we were serving prior to expansion? And so making those adjustments, but also working really closely with our community partners to identify not only our target population in need of services, but also where the community needed support and services. So we've done that through a number of partnerships, and then additionally with some investments, key strategic investments, both around healthy opportunities, but also largely around the community, what the needs are. And those are variable, and I can talk about those a bit more, but broadly, that's kind of where we've really looked at opportunity.
Yeah, thank you, Faith. Could you share a little bit more specifically about those, like what worked or what didn't, or maybe what surprised you?
Sure. I think for value-added services, when we went into the expansion population, we weren't prepared. We really, to be quite frank, we weren't prepared. We knew we had a number of offerings. We knew those offerings were quite popular with our population, but our expansion population was very different. They were older, they were wiser, they were very educated about what they needed, what they were lacking with regard to their healthcare and their social determinant needs. And so we were able to really listen to them through our member advisory committees. We have member advisory committees that we are really actively engaged with. We meet with those committees 3 times a year. We meet in every region with those committees 4 times a year. I'm sorry. We do 3 meetings per quarter. And we really get their feedback. We promise them that we'll respond to them within 48 hours of a meeting if we're unable to answer their questions in the meeting. But what we found is that they were able to really give us some strategic information about where their needs were. And then we were able to go back and work out some value adds that were amenable to that population. They were really what that population needed, but the population was able to advise us accordingly. And so that was helpful. The other thing we've done, there's a shortage of physicians in rural counties here. We have 100 counties in North Carolina, 78 of which are rural. And so a lot of what has been focused on is how do we serve those rural communities, particularly when there's a shortage of physicians, not only primary care, but specialists. And so one of the investments we've made as an organization is to develop a pilot where we're training young doctors coming out of medical school. As they're in their residency, we're placing them in rural communities so that we can hopefully recruit more of those physicians to practice in rural spaces once they've finished their training in residency and their specialties and things of that nature. And so that's a really big one for us. We're working with the Medical Society, with our FQHCs and rural health centers around educating those young doctors about what the needs are in rural communities.
Yeah, I love that. Thank you so much. So what I'm hearing from you is really keeping the member at the center and making sure you're establishing those avenues to have their voices be heard and represented, and how you're strategizing, and then also creating this nice ramp for young physicians in rural communities to be able to serve kind of your unique landscape, and especially within the rural setting. Awesome. Thank you. Liz, let's go over to you. So again, what innovative strategies or approaches have you seen in Oregon that could serve as a model for others?
Yeah, well, I would say, I mean, similar to Faith, whole person care is kind of a bedrock of our Medicaid transformation. Our state's been involved on the journey of Medicaid transformation really since the beginning of our MCO model back in 2012. So it's been a while. We've been, with the state agency leadership and our MCOs have been really building out whole person care for some time. This current waiver and its focus on social determinants of health or social needs really has just started a year ago, so it's kind of too early to say what has worked. There has been an awful lot of collaboration, both with the state Medicaid agency as well as among our MCOs themselves, who are close working partners. We're a small state. We've got 36 counties, about 4.2 million people. We do, though, have 16 MCOs. So there's just a lot of innovation, collaboration, and community work. There are also member or Medicaid member input committees through our MCO model, similar to what Faith talked about. I think with respect to our health-related social needs rollout, which is really just a piece of our Medicaid waiver, which started March of 2024. Our state, we took a phased-in approach to rolling out those services. So we started with home modifications for extreme weather events, so providing AC units, heaters, things like that, for certain populations to meet their needs. That was kind of helpful as a smaller part of the HRSN benefit to get some experience with that piece of the benefit. We then moved into housing, which started this fall, and then nutrition just rolled out in January and is still rolling out. So we kind of took this phased-in approach, which I think was helpful. I think what I would say, this isn't unique to Oregon. We are really struggling with a housing crisis here in Oregon. And so as these housing-related supports came online for the Medicaid population with strict requirements around it, it almost didn't matter because there is such a housing crisis that even though Medicaid recipients may not be eligible based on our populations that are included in the service requirements, there was just a flood of requests. And so we're still kind of climbing our way out of the flood of housing requests for services, just at a time with limited housing supply, limited housing supports in our state. So that's a current challenge that we're working on across the board with not only Medicaid, but with the other housing service agencies in our state. And I would also say we're in the early stages of building out our provider networks and helping transition community-based organizations into this whole new world of Medicaid billing and documentation requirements and authorization timelines. It's a really steep learning curve that we are still working on together.
Yeah, I think you touched on a lot. I think the phased approach is something that I've seen other states adopt or have varying different kind of ways of rolling out those programs. For the building out provider networks and again, introducing them kind of and getting them up to speed on this world of Medicaid billing, which is very different from the way that they traditionally run. Do you have any lessons learned from that specifically that you could share?
Well, again, I'm sort of speaking for our MCOs that we help convene at OHLC, my organization. I think it's still early. We had, as part of the waiver, a big community capacity building funds that were really instrumental, I think, to help some of these CBOs hire staff, get extra training, actually get computers, and really the basics. So I think that has been helpful. And then it's really been our MCOs hiring their own kind of network teams to help manage those provider networks, meeting with them often through, office hours or drop-in times. And so nothing concrete comes to mind. Again, we're just kind of really at the elbow. I would say at the elbow is really needed, especially for some of the smaller, more culturally specific CBOs who haven't, been in this Medicaid space ever before or haven't had even a grant that had such strict requirements. I think that's the highlight here, is that there is just a lot of documentation and billing requirements and guidance documents coming from our state Medicaid agency that have to be kind of translated and understood by the people actually serving the members. And so there's a lot of at the elbow assistance needed, I would say.
Totally. Thank you for sharing that. Okay, Rhonda, let's go over to you.
Thank you. Yeah. So similarly, right, we really focus on whole person health. That's very important. We also focus greatly on our community. You know, the members who are in our Medicaid plan are in our communities. We shop with them, we worship with them, we see them just on a day-to-day basis. So we're very focused on the community and really providing for our Ohana, our members, because they are part of our Ohana. One thing that we have done with the new contract, the new state contract that came out in 2021, we implemented a new CIS program, Community Integration Services, which was really focused on the needs of members who are homeless or at risk of being homeless. And that the approach that the state took to implementing that program, as well as previous programs, the EVV program, they really took a collaborative approach. They wanted to bring in the health plans, the subject matter experts from the health plans that are working with members face to face. They're working within the authorization systems, the claims payment system, and really understand where some of the pain points are, not only for the members that we serve, but also the providers that we support, and then our internal teams as well. And so the state really took point on that to say, we want to change our approach. And from implementing some of these other programs over the years, we're really taking lessons learned from there in the implementation of the 1115 waiver. And so we're building those work groups, we're taking our lessons learned and saying, you know, with the CIS program, we launched and then we had to almost do a relaunch. We don't want to do that with some of the programs that we're trying to implement now. So they're really trying to take a new approach and learning from our history and really just starting fresh, I guess I would say. You know, we are still bringing in the SMEs. I think some of the challenges with 5 health plans, we want health plans all to be heard, all different teams within the health plans. So some of the challenges that we have had is initially work groups just got too large, right? And so now they're very focused and they're saying, okay, designate one person from each health plan who can take it back. You need to work on this within your health plan, collaborating internally, but we don't need 7 different teams represented from each health plan in these work group meetings. So I think, you know, we're taking a little bit of a new approach, but I'm excited to see where we go with it.
Yeah, thank you for sharing. So you actually answered what my follow-up question was going to be. So I think for what you were calling out, obviously, of course, the concept of whole person care being at the center of everything that you all are doing. And then when you're rolling out these new initiatives, it's an interesting concept to call out of just making sure that there's a small enough group to be able to be collaborative and move things along while being able to kind of triage that, bring it back and workshop it within your own organization to bring it back out. So just learning new ways to collaborate across sectors is really important. And I think I heard all 3 of you call that out. So thank you. So I am going to go into another question for you, Rhonda, specifically. So as the leader of product management at a community-based MCO like Aloha Care, how are you designing programs that integrate both medical and non-medical services to holistically address member needs? So this concept of whole person health, particularly given Hawaii's unique geographic and cultural landscape.
Yeah, so and I think taking the geographical, which is probably the easier of the two first. We're very unique. Obviously, we have multiple islands. We have members on all of our islands that we serve, and we have to think about meeting all these needs. We don't have providers on every island, right? And so at the base of our Medicaid program, we have some uniqueness in our program where we will fly members in our island to see specialists or to see providers that can assess their needs or whatever the case may be. We also do offer services to pay for companions to fly with the members so they're not alone if there's a need for that. I think taking that into account, right? We have to challenge ourselves to be creative. And so talking through, well, does it make sense to fly 5 members to another island for various appointments with the same provider? Or would it make sense to fly that provider to that neighbor island and schedule all of those appointments on the same day with the provider? And kind of working through how can we do that? There's obviously different planning that would be involved with that, right? Making sure they have the space to see the members. But we have to think creatively. We know that there's a provider shortage. We have some very, very unique elements to our neighbor islands, right? They're small. There's not a lot of members there. So, we have to take that new approach. How can we provide them that care? It's for some folks, it can feel overwhelming. It's actually it's kind of interesting to hear some of those creative ideas and different approaches. So I welcome things like that. I think it's really important that we think outside of the box. Looking at cultural landscape, this is a much different answer, I guess. Being a local health plan founded by the community health centers, living in the community with our members, like we walk outside of our doors and we're in the community, we're seeing, the homeless that are where they're living and how it's impacting them and the communities. So we understand very intimately where the challenges are. And one example, we have also value-added services, I believe, but that was Faith mentioned that earlier. We have worked very hard and partnered with Unitas to implement a Native Hawaiian healing program, which is culturally very important to members of our community. And this is also a program that the state is hoping to add to the Medicaid program, but they haven't been able to do that as of yet. But we have taken a very different approach. It's not that we are building a program, because that's really not our area of our specialty. But what we are doing is reaching out to the community health centers and to the Native Hawaiian healing programs and saying, what do you have in place that we can help support? Because you are already seeing our members. We don't want to rebuild anything. We want to support what you're already doing. You have that trusted relationship with members. They come to you for the lomi lomi and the hula. Like we don't want to break anything that you guys are doing. We just want to help support. So that is really the approach that we've taken. Eventually what we're hoping is the state will find a way to add Native Hawaiian services to the Medicaid program. And then I think we've got a really great model to share in that collaborative work group, if that were to roll out.
Yeah, absolutely. Thank you. So from you, I'm hearing definitely a lot of provider collaboration, like very close provider collaboration, which is awesome. Liz, I'm gonna go over to you. So Oregon has long been recognized as a leader in healthcare innovation, particularly through its coordinated care model that you mentioned and these 1115 waiver initiatives. Can you share more about your role, OHLC's role in these efforts, and highlight any best practices you've seen for achieving payer alignment within a decentralized system? I know you touched on that in your intro about the way that the waiver is kind of rolling out in Oregon, but if you could kind of zoom in on that for me.
Sure. Yeah. And as I said, so OHLC, again, we're the collaborative organization. We have members who want to work together on strategic projects. One of those has been addressing social needs through a closed loop system. We've partnered, as I said, with Unitas to build the Connect Oregon network. And then along came our, new 1115 waiver with this health-related social needs benefit. So there were a number of, MCOs or CCOs, who very quickly said, how are we going to lift this? How are we going to lift this waiver? How are we going to identify Medicaid recipients who need these services? conduct eligibility screening and move them through the benefit. And so OHLC, as part of the convening work we do, convened those interested MCOs who wanted to use the Unitas payments technology to do this work of lifting the HRSN benefits. And so, as I said, 10 of our MCOs opted in to use kind of the Unitas end-to-end technology. We convened, like Rhonda was talking about, work groups. OHLC convened what we call the payments work group of those MCOs to really work together closely with each other, with Unitas as our technology partner, and to really translate our state agencies' guidance documents, OARs, and other requirements into the platform to help roll this work out. So we've been working together in that work group since actually before the first HRSN service went live, so back in January of 2024. And we've been working together ever since. It was, really, weekly work for a while. Then we dropped the cadence a little bit. Now we're actually in a monthly cadence, but we're shifting our focus a little bit from implementation to now optimization, because we've just learned a lot through here. We need some enhancements. We need some new workflows. We need to maybe think differently about the flood of our housing requests coming in and how we can really manage those and help support our Medicaid population either with HRSN or redirecting them elsewhere. So we're really in our roll up the sleeves moment here. We've convened a few in-person, really deep dive sessions, because sometimes we need to just, get off Zoom and get in the room together and whiteboard it out. So those are some of the things we've done. We've also recognized that there are some places where we can get our MCOs to align on certain ways they want to do this work. And then we also have found you need to preserve spaces for their own autonomy and decision-making, because each of our CCOs are unique here in Oregon. They've got slightly different team structures and whatnot. And so finding the places where we can align for scale and efficiency, and places to preserve individual decision making has been important.
Yeah, I love that. And then also that, I think on the flip side for the community providers, right? That's intentionally supposed to decrease their burden in trying to navigate all these different
Yeah.
unique systems and workflows, right? And so I think
Yes, that's a great, that was one of the really important pieces as the CCOs kind of self-aligned to do things together, was to decrease the burden on the provider network of those HRSN services, because we have a lot, as every state does, of Medicaid members shifting plans, and so we wanted to kind of try to keep processes and the member experience as similar as possible.
Yep, exactly. Like those transitions of care across payers, which I know, Faith, you all have a lot of experience navigating as well at Carolina Complete Health. Thank you, Liz. Faith, I'm gonna pass it over to you. So North Carolina's transition to Medicaid managed care that you mentioned has included that strong emphasis on addressing those social drivers of health through initiatives like their 1115 waiver, which they call the Healthy Opportunities Pilots, or HOPS. From your role leading population health strategy, how is Carolina Complete Health leveraging those pilots or other innovative strategies? I know you mentioned value-added services to better support whole person care for Medicaid members.
Yeah, so let me just give a little bit of background on HOP in case people are unfamiliar with it. It is the first of its kind pilot. North Carolina was selected as a site for the pilot, but it is, as I indicated, really focused on social determinants of health. The state's 4 priorities are the same priorities that are highlighted in the HOP pilot. And so, again, food insecurity, housing supports, instability, transportation, and interpersonal violence. We work with HOP on a regional basis. So it's a pilot. It is operating in various regions throughout the state. There are 3 specific regions where it's operating. We're working in one of those regions. We're working in specifically 5 counties. Our work with HOP is ongoing. So we have members who are part of the HOP pilot because they meet the requirements. The requirements are that they have a physical health or a mental health condition in addition to a social determinant of health need. That is all based on an assessment that they are done, and then their interim assessments at 3 and 6 months to redetermine whether or not their needs have grown, if they've remained the same, or those needs have dissipated entirely. Unlikely the latter, but we know that some of our members are able to transition off of HOP after some period of time. But with the increasing changes in the administration's focus in Washington, we found that there's a growing need with cuts to various programs. We're seeing more people, and we expect that that will continue. We'll see more people coming through the HOP program. We operate HOP as a solo program within the organization. We do SDOH work, or social determinants of health work, over and above that as part of the work we do in the health plan. What we have done with HOP in mind, because the state is hoping to be able to expand HOP, they've gotten approval for that as of December of 24. CMS did grant approval for the extension of the 1115 waiver to expand HOP. We were initially, I think, thinking that that could be a statewide expansion, but we don't know, with changes again in Washington, potential cuts to the federal and state budgets. That's yet to be determined by the state how they'll proceed with expansion, but we do expect that there'll be some version of expansion with HOP. Right now, they're looking at doing a tribal option for HOP specifically. We have 8 Native American tribes here in the state of North Carolina. So similar to the Aloha plan, there are Native populations that we have to be very cognizant of. We have 1 federally recognized tribe here and 7 state recognized tribes. And so there is a tribal option that is part of our Medicaid contract. And then there is expected to be a tribal option rolled out with the expansion of the HOP pilot. So we don't know yet what that will look like, but we are expecting that there will be some additional changes as well, perhaps not as fast as the state would have initially anticipated. But again, that will be predicated very much on budget, both federal and state budget determinations. But what we've done with HOP is not only operated as an independent program, we have really been working with the state and internally to think about how HOP can be sustained as a long-term model within the health plan. We don't know when that will happen, but we do know a pilot is just that. It's a pilot. It's meant to be short-term to allow us to determine what works really well and what needs some adjustment or what doesn't work at all. So we are anticipating all of the PHPs, you'll hear me refer to that, prepaid health plans, or MCOs, are anticipating that we'll be developing sustainability models that roll out of HOP. In anticipation of potential expansion of HOP, we have all begun making various investments in what are called HSOs, human service organizations, that are providing the services to the members eligible for HOP services. So whether it's housing supports, food insecurity, IPV services, those are available to both the victim of those incidents, but also to their families who may have exposure to interpersonal violence. And then for transportation, we are right now, I believe we have 11 organizations that we are funding for additional HOP support, in hopes that they will be able to either expand existing services that they're providing through HOP, or come on as a new HSO to provide much needed services. What we found with HOP is that the need has been so great, particularly with regard to housing and food insecurity, that the HSOs frequently become overwhelmed. And in Unitas, on the Unitas platform, they're able to temporarily shut their services down when they've reached capacity. And so we've had a real challenge with that. How do we get more HSOs involved with providing HOP services so that we can ensure that we're not having to turn a member away because there aren't sufficient providers who can provide the services that they need? We cannot cross counties. So while a member may live at the edge of the county and the closest available service to them is across the county line, they are unable to access that service. And so that member may need to travel across their county to get to a viable service if the only service near them is across county lines, or is unable to provide the service they need because they are at capacity. So part of what we're doing again is investing in additional HSOs so we could address the capacity issue. The other is making sure that we're thinking about how HOP is currently functioning, addressing issues around functionality for effectiveness and efficiency so that we can create a sustainable model that PHPs or MCOs can adopt long term.
Yeah, I was just making some notes, but you just threw out a bunch of good stuff there, Faith. And also kind of give a look ahead into some of the sustainability mechanisms that you all have been thinking about. So thank you. And really, I think you shared something that came up with Liz's response just about housing in general and just the capacity as we could all expect, right? But once you kind of open up these benefits, you know, the need is there. We know that. And so it's just the capacity to be able to meet that need is something that really requires a lot of different kind of layered approaches, right? Both on the efficiency side, the investment side for that long-term sustainability.
Yeah, absolutely.
Awesome. So, one question for all of you, and again, Faith, if you have anything to add, but on this topic of sustainability, this is often one of the most challenging aspects of this work. What lessons have you learned about maintaining momentum and partnerships beyond the initial implementation phase? And what advice would you offer to others who are early in their transformation efforts? And Faith, I'm gonna just pass it back to you in case there's anything that you want to double click on there. And then we're gonna go backwards in terms of where you all are in your varying phases of the work.
Yeah, I would say two important things. One is start early. So we started talking about sustainability at the point at which HOP was launched. Because the truth is we knew at some point as a pilot that it would transfer hands and responsibility. So the state wanted to make sure that the MCOs or PHPs were ready and thinking about how to run these programs. Again, it's part of the work we do already. We're already doing the social determinants of work within the health plan, but how do we think about doing it similar to the way that HOP is designed? We will probably do it a little bit differently for effectiveness and efficiency. But they started those conversations really early with us. And I thought that was a good way to go. I'm a research scientist by training. So I spend a lot of time researching and evaluating programs for outcomes and so on and so forth. So when you think about how to look at sustainability, it can't be something you think about as you begin to wind down your project, as you begin to wind down your pilot. You really need to be thinking at the beginning, how are we going to sustain this long term as we roll it out? It really helps you think not only about what you're doing in real time in that moment, but as you pivot and adjust based on what the data tells you through the early phases of your pilot, you're able to think long term about a sustainability, right? And so I think that's really important. The other that's really important for us is the partnerships. So do we have enough HSOs? Do we need more HSOs? Where do those HSOs need to be? For us, because North Carolina is so heavily rural, we know that we need those partnerships in rural communities. What we find in rural communities is that there aren't as many resources, right? Because the space is so broad and expansive that people aren't necessarily close to resources, and the resources are not plentiful. Churches tend to be huge resources in rural communities. Unlike HSOs or CBOs, there aren't as many of those in rural communities, but there are faith-based opportunities everywhere for partnership in rural communities. And so looking at where your partnership is, what's the best place for that partnership? Is it a rural area? And what does that look like? Where do you need those partnerships to be? Local health departments are very big partners for us when it comes to working on maternal health, because all of the maternal health for Medicaid runs through local health departments. There's a local health department in every county. So we're able to go into those communities identify what the target population is, where are the risk factors, and let's start talking and working with those community organizations that are going to help us impact outcomes. The other for us is tribal communities. What we did was, as a group, all of the PHPs in the state of North Carolina work as a collective whole in our effort to address the needs of tribal communities. We meet as a group, we convene our tribal advisory committee as a group, we enter communities for engagement opportunities as a collective. That reduces the burden on the Native population, on the individual tribes, trying to coordinate with 5 different PHPs. We go in as one entity. We all are there for the same reason. We want to ensure that our members are getting the best possible care, in that we're able to work as a collective group to meet the needs of tribal communities.
Yeah, thank you for sharing that. So I heard start early, which I think, to your point, sustainability can't be an afterthought. And I think with the state having those conversations with you all early on, that kind of sets the tone that it is going to be your responsibility to figure out how to sustain the program long term, as long as the ROI, of course, is there. And then partnerships, every type of partnership, every way you look, up, down, left, right, with providers, HSOs or CBOs, members, and then with your fellow payers.
Yeah.
Awesome. Thank you. So Liz, I'm going to pass it over to you on the topic of sustainability.
Sure. I mean, a lot of what Faith said definitely resonates with me. I think I would think of this in 2 parts for us right now, where we are, very early in our implementation. I think of it at the ground level, like what does sustainability look like for our HRSN service providers? And then what does sustainability look like for these services as part of the Medicaid program, when the waiver, is done. And so on the first one, I think maybe we didn't start early enough on thinking about service provider sustainability. Perhaps, I mean, our waiver was rolling out in phases. It was, kind of a very fast pace rollout. Our HRSN service providers, which is what we call the CBOs who are billing for these services, can bill under fee schedules as published by our state Medicaid agency. I think we're all starting to think about, okay, how does that actually sustain them once capacity funding is gone, which is like grant funding for 18 months? How many Medicaid members, clients do they need to be serving to really keep this HRSN program team in these service providers sustainable? Right. So we're kind of starting that work now. What does it look like to have a team of service providers or teams within service providers doing this work? So I think that's very active conversation with the MCOs now. And then for the sustainability of these services overall, as part of our state Medicaid program, we have 2 evaluations that are starting now. One, of course, is the state Medicaid agency formal evaluation as part of the CMS waiver. So that's beginning. And OHLC also has a partnership with UC San Francisco's Siren team, the Social Interventions Research and Evaluation Network. We did some early implementation work with that team, and then they used that to apply for an NIH funded grant to really now look at connecting Medicaid beneficiaries to social needs and the impacts on health utilization and health outcomes. So we're really going to need the results of that work to see if the ROI is there, where it worked, where it didn't, to really help us with sustainability for the long haul of the as part of Medicaid benefits.
Yeah, absolutely. So you called out at the ground level on the HRSN service providers side, and I think that's a really important thing to be thinking about constantly. I've seen some literature come out of North Carolina actually on that topic, and North Carolina, I know we didn't really get into all of the different models, but North Carolina is leveraging kind of this community care hub model. They call them network leads in North Carolina, which I know isn't something that Oregon is using or yet. But I know that there has been some stuff that's been put out about how they are kind of playing that intermediary role between service providers and payers to help on that end. And then, of course, everything needs to be evaluated. I think, Faith, you called it out, and it's in the Healthy Opportunities pilot title. These things are a pilot, right? So they're really serving as a way to innovate with these Medicaid funds, but we need to prove out the ROI. It's all of our responsibility to be able to prove out that ROI so that these programs can be sustainable. So thanks for calling that out, Liz. Rhonda, I will pass it over to you to talk about sustainability, knowing that you are in the very early phases.
Yeah, and we definitely are, but I mean, I go back to some of the previous programs that we've implemented, right? And as much as we would like to say, even if we do a pilot or however we roll out a program, we would love it to be what we need in the future. But as we all know, the environment changes, the needs changes, the direction, what's coming down from regulators changes. So we have to be flexible. And we have to be willing to say, even without all those outside influence, we have to be very critical of the program that's been deployed and realize when something isn't working right and needs to be adjusted. So that's the one thing that I really think it's just that willingness to be flexible and be critical of what's been deployed and what is truly working and make those small corrections. Small corrections are a lot easier than a total revamp of a program. So if you make those small corrections, it's just much easier to do. I think the other piece of it that I would say is communication is key. Communicating with your partners, making sure that they understand what is potentially coming, whether it's partners within your own organization, whether it's provider partners. Communication is so key that they understand what's happening and what's coming their way, and that will help for that adoption. And that adoption is so key in the sustainability. So that's really my short answer. I think communication is high up there, but then the flexibility is so important.
Well, you summarized for me, so thank you, Rhonda. But totally. And I think that's something that maybe hasn't been mentioned yet, the need to be flexible. And so in these types of programs, it's really important to be able to have access to real-time data, be able to look at how things are performing in a number of different areas, both on the, actual program performance level and then on your member level, right? To be able to make those changes in real time. On that note, so those were all of the kind of prepared questions. We did have some questions come through the chat. We have 8 minutes, so I don't think we're going to get to all of them. But I did want to, this one is kind of related to what you all were starting to get at, which is the idea of measuring success. So obviously understanding that success may look different in different phases of these waivers, but how are you all kind of defining and measuring success, particularly when it comes to integrating these, non-medical services into your typical healthcare and addressing social needs? So Faith, I saw you come off mute, so I'm going to go over to you.
Yeah, I think one is going to be utilization. Is it something that members need? And if so, are they using it? Are we making access to these services readily available? What we've done is we've automated pretty much everything. The member can go right into the member portal. They can sign up for any service that they're eligible for. And then we process those. We'll tell them in real time, this is when you can expect to receive it. So whether it's a new parent package for moms who are expecting or new moms who've given birth within a year, whether it's a voucher, we've made it really easy for after school. Parents need a place to have their children safe after school. We've created a system where they can tell us what's in your local community. We did the big stuff. We did the Y and the Boys and Girls Club, and that's all well and good, but those things aren't everywhere. So our rural families said, hey, what about 4-H? Yep, we can do that. Let's talk to your local 4-H. We can sign them up. We can have them be a vendor for our rural community. You let us know what's in your community. What do you want your child to do? You may want your child to go to a museum. They may have creative tendencies. Tell us that. We'll work with your local museum so that they can go to programs at those sites. But one is utilization. Two is really making access easy. I think the other is really talking to our members. We host those member advisory committees on a quarterly basis. As I said, we do it in every region we serve. our numbers are humongous. We can get up to 200 members in a single meeting, telling us what they need, what they want. We ask them for feedback. They give us their feedback. We come back in our next meeting and we show them what we've done with regard to the feedback that they provided us. That encourages them to continue to be active and involved in their care, letting us know what's working for them and what isn't. The other is being able to respond in real time. You know, if our members say they need something, our response time is no longer than 72 hours, whether we're going out to do a home visit or we're following up telephonically, whatever it is, we're responding as quickly as we possibly can to what the members' needs are. But what's working is, what do they need? What do they tell us that they need? What is our data telling us about care gaps? Where are we seeing gaps, and what can we do to affect change in those communities? And that means that we're going out and connecting with our partners who are in those local areas, who are already doing this work, connecting with them to continue to build on, as Rhonda said, work that's already being done, so that we don't have to recreate the wheel. As Liz said, you're taking what's already there. What do they do well? Let's figure out how to connect with them so that we can work with you in concert to deliver those services.
Thank you, Faith. So I heard a lot there. I'm not gonna recap because I don't have time to, but I'm gonna pass it over to Liz to share some too.
Yeah, I think a lot of what Faith said, of course, I think the four things that come to mind for me are Medicaid recipients getting services in a timely way. We're currently struggling with timeliness right now, just because of housing needs are so high. So we're working on that, with provider capacity, support, given constraints there. And then, downstream, are we having, or further down the line, are we having impacts, like I said, on utilization and health outcomes? We, of course, need that. I think also, how do members feel about getting these services from their MCOs? Are they satisfied? Is it in a way that that it supports them? And then, the larger one is, are our MCOs able to continue to provide these services if our federal waiver funds go away or are not renewed? What does that look like? That would define success if we're able to continue to provide a lot of these services, because we are committed to whole person care out here in Oregon.
Thank you, Liz. And last but not least, Rhonda, I'm gonna pass it over to you before I close us out.
Yeah, thank you. So I would just add, definitely share what Faith and Liz had commented on. I think the outcomes are critical, right? You need to look at the outcomes of the members, not just in stars or AWVs, but really what is happening with their health. What I will say, and I heard this earlier in the year from a local group, and what's very frustrating for members in some local groups is they're seeing a lot of data about them without them, meaning they're publishing data about their community, but nobody's asking them about it. And so talking about what we're seeing in outcomes with the groups, the different organizations that are out there, community organizations, I think is very key. Does this represent what they believe is happening? Do they know why some of these changes and outcomes might be happening that maybe we are not seeing? And so having those lines of communication, I think, is key for us.
Awesome. Thank you. So across all of you, I was hearing kind of those process indicators, right? So access, utilization, timeliness, things like that. And then for farther along thinking, really on the health outcome side, are these interventions actually working as we anticipated? And then across everyone, just the need to be flexible, rapidly changing, leave your ego at the door, for these programs that we're building, because we're doing it really at scale for the first time altogether. Thank you all so much. I wish I could have this conversation with you all for like 5 more hours because there's so much I would want to get into, but thank you for giving us an hour of your time. Appreciate everyone for joining us. Conversations like these are obviously so important, and we look forward to bringing our partners together more and more in the future to be able to discuss ways that we can continue to build healthier communities and all further this work in our different roles across the country. So thank you. So a couple of housekeeping items. One, I know we didn't get it to all the questions. I apologize. So where we can, we'll be able to follow up personally with you all to respond. This webinar, excuse me, was recorded, which I know was asked in the chat. So we will be able to share out the link. And just in general, if you're interested in learning more about how we support this work, Unite Us, you can visit our website and request a demo or request to talk to us, and we'll set that up. So thank you again, everyone. Thank you, Faith, Liz, and Rhonda, so much for your time and all of your insights. Really appreciate it. And have a great rest of your Wednesday.
Thanks for having us. Thanks, everyone.
Thank you.
Aloha, thank you.